You're a Tato. What we're going to learn about today is pancreatobiliary pathology. We have several must-knows. Must-know number one is normal structure and function. I know that you learned this when you were in ELM, but we're going to quickly revise it. Here we go. Remember the anatomy. The gallbladder is connected to the common bile duct. And then that joins the pancreatic duct to go out into the ampulla of Vata. There are lots of anatomic variations of this, which is something surgeons really need to know, but pathologists just need to note it and move on. More pertinent to us is the production of bile. So bile is produced in the hepatocytes, travels down the canaliculi here, backwards into the portal tract. Remember, the blood's going this way in the portal tract. The bile goes down the canaliculi, and then it ends up in the hepatic duct and goes into the gallbladder. What is in those biliary secretions? We have bile pigments, cholesterol and phospholipids, all kinds of stuff like metabolites and drugs that have been excreted. There's some bicarbonate to neutralize acid, and there's bile salts, both newly synthesized and recycled. It's a complicated mixture, and it's all kept in solution by lecithin. Here we go. So here is a diagram of bile salt circulation that has been taken directly from your ELM notes. So remember, bile salts can be made. Some go to the gallbladder, some go out. Then they get reabsorbed after they've gone into the intestine and recycled. Only 5% is lost in feces. So, number two. Formation of gallstones is very common, and there are different types, and they are associated with different etiologies. The most common type of gallstone is the cholesterol gallstone, pictured in the bottom right here. Cholesterol stones tend to be these faceted pale stones. There are pigment stones made of bilirubin and calcium salts. So these are high in hemoglobin products and usually occur in populations where there's lots of hemoglobin breakdown. And then there's mixed cholesterol and calcium bilirubinate stones. These are really, really common. When you cut them open, they have a nice laminated look. Let's think about cholesterol stones. So normally bile salts dissolve cholesterol vesicles, but if the bile becomes supersaturated, then cholesterol crystals form and they condense into these little stones. Usually there's a nidus that they collect around, and then the stones start to grow so much that the gallbladder can become quite packed with them, as in the illustration. Cholesterol stones are typically found in middle-aged to older people, though they can be found in young people as well. 15-year-olds can sometimes get gallstones. Classically, they're found in women more than men, and in European-derived populations rather than other populations. They're associated with increased weight, some drugs, and pregnancy increases the risk of gallstones. Pigment stones, so normally bilirubin is secreted into bile, and mostly it's conjugated, which is soluble, but some of it is unconjugated, which can form an insoluble precipitate with calcium. So anything that increases the amount of bilirubin, of course, is going to increase the number of stones. What causes pigment stones then? High heme turnover, such as hemolytic anemia and sickle cell anemia, cirrhosis, some liver infections, particularly liver flukes. They occur more with increasing age, and they are typical of non-Western populations. In Aotearoa, they're particularly found in Asian populations. Why are gallstones bad? Because they can cause a whole lot of complications. They can escape from the gallbladder and cause blockages at various levels. And the consequences of these blockages are numerous. They can also go and cause irritation in the gallbladder itself, leading to carcinoma of the gallbladder with the chronic inflammation, epithelial turnover, and the carcinogens that might be present. Let's go through some of these complications of obstruction. So acute and chronic cholecystitis. Chronic cholecystitis occurs because of irritation of the gallbladder wall, causes the gallbladder wall to become thickened, chronically inflamed. So you get a thick, chronically inflamed gallbladder. If there is infection in this static stone-filled gallbladder, then it can become acute cholecystitis. It can also happen if there is a stone impacted in the neck of the gallbladder. Similar to the appendix, the gallbladder swells and causes ischemia and acute cholecystitis. Biliary colic can be caused by gallstones passing down the common bile duct and causing intensely painful contractions, a bit like renal stones passing down the ureter. Ascending cholangitis is where a stone is in the gallbladder, maybe not enough to absolutely block it, but infection travels upwards from the intestines and into the liver. A gallbladder mucocele is where a stone is impacted in the neck of the gallbladder such that nothing can get in or out. So no bile salts or bilirubin can get in and out, and everything in there is absorbed, and then the lining of the gallbladder continues to secrete mucus, thus forming a mucocele. Gallstone ileus is where a large gallstone forms a hole in the wall of the gallbladder, which becomes adhered to the small bowel, and the stone passes into the small bowel and blocks it, causing ileus. And finally, pancreatitis, one of the most common complications of gallbladders, of gallstones, where the gallstone can be impacted in the pancreatic duct and therefore cause obstruction. We're going to address pancreatitis in a little while. Okay, so mixed stones, again, they're often faceted. They have this layered look, packing out the gallbladder. So let's think about where stones can be and cause problems. What I want you to do with this one is just pause the video and label each of those points in your mind even. What are those stones causing? So if they're in A, they can cause gallbladder cancer. If they're in B, they can cause ascending cholangitis. C would be jaundice and biliary colic. D would be pancreatitis, and E would be gallstone ileus. Let's move on to must know number 3. So must know number 3 is acute and chronic inflammation of the gallbladder is a common surgical issue. These are the clinical features of acute cholecystitis, the classic right upper quadrant pain, which can radiate to the shoulder or back. It's a steady, severe pain in acute cholecystitis, not the coming and going of colic, often associated with nausea and vomiting and fever. It causes a white cell response. There's a mild increase in bilirubin and liver function tests, but the common bile duct isn't blocked, so you don't get a very large increase. My little arrows have got out of sync here. We'll just move them a bit. Oh, here we go, improving improving it on the run. There we go. All right, that's better. So acute cholecystitis, 90% of cases are due to stones, which obstruct the neck of the gallbladder or cystic duct, leading to an increase in intraluminal pressure, just like the appendix becomes obstructed by fecaliths. Gallbladder distends, right? The distended gallbladder impairs blood flow, particularly venous outflow and lymphatic flow, which leads to ischemia. And then there's also direct mucosal injury due to the intraluminal pressure. Chemical irritation is common in both acute and chronic cholecystitis. And bacterial infection is a secondary event in acute cholecystitis because of the stasis. Mainly the problems arise because of the pressure effect of the gallstone causing swelling in the gallbladder. Okay, so here we go. Here's a gallbladder and we've got a giant stone in it here and multiple smaller faceted stones. This gallbladder is looking extremely unhappy. It is very red and swollen because it is suffering from acute cholecystitis. So about 10% of cases of acute cholecystitis are not due to stones. This is called acalculous acute cholecystitis, and it is due to conditions that cause biliary stasis, like surgery, sepsis, trauma, long-term TPN, catastrophic cardiac events, and sometimes salmonella infection. In all cases of acute cholecystitis, the gallbladder becomes enlarged and tense, very red to greenish black, so greenish black when it's becoming gangrenous, and it's often covered by a white fibrin coat when you look at it from the outside. The inside contains like bile, or if it's become infected, it becomes pus, and it has a very thick edematous wall. Let's have a look at that again. This red gallbladder, it kind of looks soggy, really, just soggy. We know this gallbladder's had some high cholesterol in it because it's got this thing called cholesterolosis showing, where we get this pattern of pale networky events happening because of cholesterol-laden macrophages in the mucosa. What is the complications of acute cholecystitis that make it a surgical problem? So the first is that we can get overgrowth of bacteria in there, leading to empyema. It can perforate, leading to an abscess and peritonitis, and it can cause systemic sepsis. Sometimes surgeons will calm the acute cholecystitis down with antibiotics and other treatment, and they then can operate as an interval, or sometimes it's taken out acutely. All right, chronic cholecystitis. So chronic cholecystitis is a condition where people have gallbladder problems for many years. We know that it is associated with stones, but we don't completely know the pathogenesis. We know cases of chronic cholecystitis can have intermittent attacks of acute cholecystitis. And we also know the pressure of stones against the wall can lead to localized ischemia. We know that just the supersaturation of bile, which causes stone formation, can also cause inflammation of the wall. Whatever the cause, what happens is we get progressive fibrosis and thickening of the wall with chronic inflammation. So macroscopically, we have a thickened wall. The gallbladder there at the bottom shows a very thick gallbladder wall. And macroscopically, we see chronic inflammation with fibrosis, muscular hypertrophy, and these things called Rokitansky-Ashoff sinuses, which I will explain to you in a moment. Sometimes the whole gallbladder becomes calcified, and then we call it porcelain gallbladder. Onwards. Okay, so this is a picture of chronic cholecystitis. showing that we've got chronic inflammation in the wall. Remember, the gallbladder is normally lined by this epithelium. This is emphasizing the fibrosis and muscular hypertrophy. These are Rokitansky-Aschoff sinuses. They're little like diverticulae in the gallbladder where we get mucosa outpouching through the wall. And you can see all the chronic inflammation going right the way through this gallbladder. I mentioned cholesterolosis earlier. This is cholesterolosis. This is where we get macrophages imbibing the excess cholesterol and forming these little foamy groups in the mucosa, and it gives this network pattern on the inside of the gallbladder. Okay, must know number 4, gallbladder cancer is an uncommon but deadly disease. Gallbladder carcinoma is quite uncommon. It's found in very few cases of gallbladder, it's found in very few cases of gallbladders with stones, and stones are its most common association. So people who have stones are at risk of gallbladder carcinoma. Most are adenocarcinomas. They arise through a dysplasia sequence, just like carcinomas in other parts of the body. They can be exophytic, in other words, they can form a polypoid cancer, or they can just directly infiltrate that wall. It's quite a silent cancer, so at discovery, it's often quite advanced in stage and has invaded the liver, the lymph nodes, and the adjacent biliary duct. Let's have a look at some pictures. This is an exophytic gallbladder cancer. So this is here, I've got some stones, some cholesterol stones, and here's the gallbladder cancer. This is why when people have ultrasounds and they find polyps in the gallbladder, people get a bit excited and take the gallbladder out because they want to make sure that it is not a dysplastic polyp that might be a gallbladder, might progress to a gallbladder cancer, or might actually be a gallbladder cancer. What do gallbladder cancers look like? Well, let's use the classic adenocarcinoma descriptors. Malignant glands invade the wall. You can see them here. Yep. And the glands are lined by pleomorphic, mitotically active hyperchromatic cells. Must know number 5. Carcinoma can occur so carcinoma can occur in the bile ducts, either the intrahepatic bile ducts or the extrahepatic bile ducts. And this kind of cancer is called cholangiocarcinoma, and it often presents as jaundice. So cholangiocarcinoma, the carcinoma of the biliary ducts. Here's a picture of it. Here we have a duct coming into the small bowel. This is the bit of pancreas here. And here in the common bile duct, we have an infiltrative cancer. You can see it's completely blocked it off. So this person will have jaundice. What are the signs of gallbladder cancer? Usually it can present it presents as fibrotic strictures. There are other causes of strictures. You can just get strictures from inflammation, particularly in people who have liver flukes or if they have inflammatory bowel disease. Okay, but some of these strictures will be cancer and so have to be biopsied. All of the strictures cause jaundice. Here we go. So a common place to get bile duct cancer is right at the end of the bile duct system at the ampulla of Vata. And here we can see we've got this, I'm just trying to get my anatomy here. This is the common bile duct, which is dilated. This is the small bowel here. And this is the carcinoma of the ampulla of Vata. And we can see here, oh, got my ducts wrong here. Sorry, this is the common bile duct. This is the pancreatic duct here. This is the small bowel. This is the histology here where we've got the small bowel. This is the common bile duct, pancreatic duct, and it is obstructing both of them. So what are the clinical presentations of carcinoma of the ampulla of Vata, or in fact, any obstruction, any carcinoma that is obstructing the bile ducts. The first is you get obstructive jaundice, characterized by pale stools, dark urine, nausea, vomiting, weight loss, and elevated liver enzymes. Remember, stones can cause this, as can fibrosis. Most ductal cancers aren't resectable at the time of diagnosis. The ampullary Vata ones are the exception. So the treatment is often stenting so that symptoms are relieved, but unfortunately, the cancer continues to progress. Must know number 6. We're going to the pancreas now. So let's think of normal structure and function of the pancreas. Again, these are pictures from your ELM notes. Okay, well, this is complicated. So the pancreas is nestled here, remember, where the duodenum turns the corner and becomes the ileum. It has a tail, a midsection, and a head, and it has a whole lot of ducts intimately associated that run behind it. There's a bunch of lymph nodes up here and lots of nerves. So it's intimately entwined with the structures of the upper part of the abdomen. There's an endocrine pancreas and an exocrine pancreas, which are kind of all mixed up together. The endocrine function occurs in the islets, most famously known for producing insulin, but also other things like glucagon, somatostatin, and pancreatic polypeptide. And then there's the exocrine function, which is the one we're going to address mostly in this surgical pathology talk. And it produces digestive enzymes. So this is what the normal pancreas looks like. I've never eaten one. I can't bear to eat organs after being a pathologist, but you might have had these sweetmeats at the fancy restaurants. All right, normal pancreas. Normal pancreas has islets in it, and these are the ones that produce the endocrine hormones, and then it has acidae, which produce the digestive enzymes. Yep, and the digestive enzymes go into the interlobular duct, so into the little intercalated ducts, the intralobular ducts, and then these larger intralobular ducts, which drain into the pancreatic duct here and head out into the small bowel. All good, good revision so far. So here we go. So stones are a cause of pancreatitis, and the position of the stone can influence what symptoms we get. So if we think about where the stone is, if it's just here in the common bile duct, here it'll cause jaundice, etc., because it doesn't affect the liver. Because it is affecting the liver. If it's stuck here in the ampulla, then it will affect both the common bile duct and the pancreatic duct, and sometimes it can reflow in the pancreatic duct, and you just get pancreatitis and not jaundice. All right, let's think a bit more about the exocrine pancreas. What does it produce? Well, it produces a whole liter of stuff a day, alkaline fluid to sort out that residual acidity from the stomach, and digestive enzymes. Amylase, which digests carbohydrate. You remember where else produces amylase? Yes, it's salivary amylase. It produces enzymes that dissolve nuclear DNA type stuff, ribonuclease, deoxyribonuclease. Very, very importantly, it produces lipase. This causes a ton of trouble in pancreatitis, and phospholipase. And it produces trypsin and chymotrypsin, which dissolve proteins. Okay, a lot of the enzymes are secreted by the pancreas as proenzymes and get converted into active enzymes. Okay, so inactive enzymes with inactive enzymes are caused to become active enzymes by trypsin. Trypsin itself is activated by a membrane-bound enterokinase on the epithelial cells. So the pancreas usually doesn't dissolve itself because it has inactive enzymes secreted. All right, must know number 7, acute pancreatitis is a common cause of acute abdomen and presents in a mild form or up to a very severe and life-threatening form. Let's think about acute pancreatitis. What are the symptoms? Sudden onset of abdominal pain, which intensifies and radiates to the back, associated with nausea, vomiting, shock, fever. It sounds a bit like acute cholecystitis, actually, doesn't it? But it's often actually quite severe. And then we get the other signs. People often go slightly shocky with tachycardia. There's tenderness and guarding, and there's abdominal distension, sometimes because of the pancreatic-related peritonitis. So what are the symptoms that we see? Those are the symptoms that we see. We get elevated serum amylase and lipase. You will get pancreatic enzymes taught in your liver tutorial. At the moment, I think we just test for lipase. Check that out because I could be behind in my knowledge of chemical pathology. There are lots of complications from pancreatitis, mainly related to shock. 5% of people with acute pancreatitis die of shock. Lung disease, adult respiratory distress syndrome related to shock. Acute renal failure related to shock. Sepsis related to the pancreatic enzymes becoming activated and dissolving stuff in the abdomen. It can form abscesses and this complication called a pseudocyst, which happens at the tail of the pancreas, and we will address shortly. Okay, this is a CT of pancreatitis. So here's the pancreas. And we can see that there's these white streaks. And this is because the pancreas is releasing lipase and activated trypsin and dissolving itself and forming this kind of chalky mess. Here we go. So this is acute pancreatitis. So the trypsin, it dissolves proteins, it dissolves blood vessels. And when the blood vessels dissolve, they form hemorrhage. Yep. And when the lipase comes along, it dissolves the fat and gives rise to this solid, chalky kind of stuff. So this is the omentum, and this is the cut part of the omentum, showing it dissolving itself. Here we go again. This lot's been fixed in formalin, so it looks slightly different, but again showing the hemorrhage and dissolving the fat, particularly here, forming a kind of whitey, chalky look. This bit here is the specimen above cut in half, and we can see that the normal fat has now become this white, chalky. This is the normal fat here, white, chalky looking stuff with necrotic fat in the middle. Lipase released wild into the peritoneum is causing this. So what causes acute pancreatitis? So 3 things. Number 1, biliary tract disease, right? Those stones. Number 2, alcohol. So how does alcohol cause acute pancreatitis? Well, people who drink alcohol in large amounts secrete thick secretions into the pancreas, and those thick secretions obstruct the ducts. And once the ducts are obstructed, then of course the pro-enzymes become active enzymes, and off we go with acute pancreatitis. If the pancreas becomes ischemic if the pancreas becomes damaged in other ways, like trauma, trauma from a car injury or from an ERCP, this is where they put the camera up the bowel and pancreatic ducts, infections, tumor or metabolic disorders, it can also cause acute pancreatitis. Let's look in more detail at acute pancreatitis, the pathogenesis of acute pancreatitis. Okay, so this is the pancreas, this is the pancreatic duct, the small bowel is on this end. So obstruction, gallstones in the common bile duct, or thick mucus of cystic fibrosis, or chronic alcoholism, or tumor, or maybe duct spasm, okay, causes obstruction of the pancreatic duct. What happens then? So everything backs up, right? So we get this high pressure system backing up. We get enzymes leaking into the blood, so we can detect them, and into the tissue where it causes problems. The backup also causes damage to the actual acinar cells. Plus, acinar cells can be damaged directly by alcohol, viruses, drugs, trauma, and some hypocalcemia and hypolipidemia. And they can also leak things directly into the blood. What happens when it gets out there? Well, the first thing is you can get an increase in enzymes in the blood. Then it causes that fat necrosis that I showed you. Then it, through the lipase, the proteases, trypsin, cause blood vessel destruction and hemorrhage. And this forms the complex of acute pancreatitis. Here's another way to describe it that I am not going to go through, but if you're still not understanding, I suggest that you pause the video and look at this diagram. It's fairly straightforward, just nice kind of idea of one thing leading to another with pancreatitis. This is a great exam question, right? So you should, if you think you understand it, stop the video, switch off the screen, and try and answer the question, what is the pathogenesis of acute pancreatitis? Okay, so you'd start. No, I'm not going to tell you the answer just now. You've got to turn off the video. Okay. I'm presuming you've come back now. You've got to start with what causes it. Sorry, no, you've got to start with the landscape. Acute pancreatitis is caused when there is damage to the pancreas. Number two, it can happen in 3 different ways. The red things at the top. The 3 different ways lead to acinar cell injury. Number 4. Is that number 3? And can also directly damage the duct, leading to release of activated enzymes, which cause interstitial edema, proteolysis, which leads to hemorrhage because the blood vessels are dissolved, and fat necrosis. We are up to must know number 8. Okay, chronic pancreatitis. Chronic pancreatitis presents in various ways and is associated with a number of different causes. Here is one of these nice flow diagrams again. All right, chronic pancreatitis. Alcohol leads to early duct obstruction. Not enough to cause acute pancreatitis, but enough to upset the pancreas and cause these stellate cells to activate. They're kind of fibroblasts, right? So alcohol, early duct obstruction, fibroblast activation. Chronic pancreatitis can be also caused by multiple acute pancreatises and other toxic things. The end of the pathway is still the pancreatic stellate cell activation, the fibroblasts. Fibroblasts, what do they do? They attract inflammatory cells, particularly through pro-inflammatory cytokines, and then chemokines, and then you end up with chronic pancreatitis characterized by fibrosis and chronic inflammation here. And then with the fibrosis, of course, fibrosis contracts and you get duct obstruction and increased duct pressure. It contracts around the ducts. And then what do? We cause more damage to the pancreatic acinar cells. And here we go in a loop that causes ongoing fibrosis of the pancreas. This is a fibrotic pancreas. It is a particularly boring picture, but you can see that the bile duct, the duct here is narrower than normal. And the pancreas, it's not looking hemorrhagic or anything, but it's just looking a bit bland. Okay, so here we have the pancreas again in chronic. This is really advanced fibrosis. So we've got a bit of normal stuff here at the tail, which is relatively protected, which is why you don't often get abnormalities in insulin production with chronic pancreatitis until the last stage, because you still have the islets in the pancreas going for it and producing insulin. But look here, we've got all this fibrosis that is obstructing the duct. Here's a blood vessel probably that has been thickened by chronic inflammation as well. Okay. I am not sure why this picture is here. Let's make it go away. All right. So here's a picture of chronic pancreatitis. So now, rather than wall to wall, little acini packing out the place, what we've got is reduced acini and increased fibrous tissue surrounding the lobules. Here are the surviving ducts, also surrounded by fibrous tissue. You get chronic inflammation. It's an advanced chronic pancreatitis, chronic inflammation and fibrosis, which has destroyed all the acini, and all we've got left is the islets. The islets are the survivors, which is why, as I said, you don't get endocrine pancreas problems until late. Sometimes you get duct proliferation associated with chronic pancreatitis. So we've got some duct proliferation, and here is the surviving acini. Okay. So here's the summary for chronic pancreatitis. Alcohol is the most common cause. The next most common cause is repeated duct obstruction, causing minor episodes of acute pancreatitis. Metabolic disease with hyperlipidemia and hypercalcemia can cause damage to the pancreas. Cystic fibrosis can cause damage to the pancreas. And then there's a bunch of other stuff. So this is your Vindicate. And sometimes we just don't know what causes the chronic pancreatitis. So again, the summary, it's a chronic progressive disease leading to permanent loss of pancreatic exocrine function, leading to malabsorption and steatorrhea. Pancreatic endocrine insufficiency occurs late in the disease. Symptoms wax and wane over the course of the disease, and the treatment is pancreatic enzyme replacement, pain control. There's a ton of nerves around that pancreas, and of course, stopping the offending agent. Okay, let's think of a different kind of pancreatitis, autoimmune pancreatitis. So this is a rare condition. We know that autoimmune stuff is a cause of a lot of type 1 diabetes, but we aren't talking about the islets here. We're talking about the exocrine pancreas. So this is one of the things that causes the 25% of idiopathic pancreatitis. You get an autoimmune reaction to the pancreas that is in the exocrine pancreas. It's one of the IgG4 diseases. So IgG4 is trouble. It is very, very good at causing fibroblasts to proliferate. It causes diseases such as fibrosis in the orbit, retroperitoneal fibrosis, and also can cause fibrotic pancreatitis. It can often mimic pancreatic adenocarcinoma because it just causes this big fibrotic lump, which is kind of what cancers look like. But it does respond to steroid therapy. So it's really important to diagnose because this is treatable, unlike pancreatic cancer. Number 9, pancreatic cancer, which is actually a relatively common malignancy of middle age and older individuals. It has a rising incidence and is very, very difficult to remove surgically, so has a very poor survival. So let's think of a typical case of pancreatic carcinoma. We have an 80-year-old male with malaise and anorexia and weight loss. There appears to be some bile obstruction because there is itching. It has loose bowel motions, which are pale in color. Again, he's probably obstructing his bile duct as well as his common bile duct. Sorry, his common bile duct as well as his pancreatic duct. He has a nondescript past clinical history, no allergies, lives alone, and has had heavy alcohol use for many years. This is an important part of the history. On examination, we would find a thin, frail man with yellow skin because, of course, he's got obstruction of the common bile duct. He's got scratch marks because it's itchy. We've got ascites, an epigastric mass, and an enlarged liver with an irregular edge. Why? Why would we have an enlarged liver? Let's have a little think about why. Yes, he might have metastases there. So he has a CT. This is his CT. We can see that there is this large mass at the head of the pancreas here. How are we going to treat him? Well, we can treat him symptomatically. He can have a stent put in to relieve his jaundice. And at the same time, he can have brushings and also a biopsy if needed, but brushings are usually quite diagnostic. This is where, the cancer's obstructing the duct and they have a brush that they put down the endoscope and collect cells from it. So we can see malignant cells when they submit it to the cytology lab. Often there's a raised CA 19.9 antigen level in pancreatic carcinoma. There are some chemotherapy regimes for pancreatic carcinoma, but in this case, the patient declined them and passed away 6 weeks later. So one of the reasons why this is very, very difficult to operate on is 75% occur in the head and neck of the pancreas. And it's there with all those important and delicate structures that it spreads into early and becomes inoperable. Some are in the body, a small amount are in the tail. And these are, of all pancreatic carcinomas, most of them are ductal carcinomas. They arise from the ducts. There are very few carcinomas that arise from the acini, but mostly pancreatic carcinoma is pancreatic ductal carcinoma. So here we go. Let's have a look at trends in cancer survival. So here is pancreatic carcinoma. I'm just going to have to move myself. Right, so it is unfortunately not improved. So we've had big improvements in survival of other kinds of cancer, but there's been no improvement in survival rates for pancreatic tumors. Unlike, for example, skin cancer, breast cancer, prostate cancer, bowel cancer, where we're doing much better at treating people. Okay, so often these cancers grow silently deep inside the body, and they only give symptoms when they've, for example, obstructed the bile duct or metastasized to the lymph nodes and liver. Often they give non-specific symptoms like malaise and weight loss and nausea. When they invade around the nerves, they can give epigastric and back pain, but are inoperable by then. Okay, so most are ductal, highly invasive, occur at the head of the pancreas and obstruct the common bile duct, leading to distension of the biliary tree. Let's have a think here about what they might look like. They look like this mass. There's a mass at the head of the pancreas here. A mass. So it's going to be hard, and you can guess what it's going to look like down the microscope because it's an adenocarcinoma. Again, it can have a precursor phase, so pancreatic in situ neoplasia. So this is again a tumor that goes through the sequence of dysplasia through to carcinoma. And the dysplasia is caused by increased epithelial turnover from things like obstruction and alcohol. And once it gets to be invasive, then we use the adenocarcinoma descriptors, which are common to all adenocarcinomas. We have malignant glands infiltrating through pancreatic and adjacent tissue, composed of pleomorphic, mitotically active neoplastic cells that form ducts, trabeculae, and isolated cells. Yeah, so how do we diagnose them? People have got quite good now with clever endoscopic technologies, which you will hopefully see when you go to the gastro clinic. So we've got the endoscope that goes down through the mouth, and it can can generate all kinds of things, as well as take biopsies with, needles. It can have an ultrasound tip on the end, so we can get great ultrasound images as well. Okay, let's move on to must know number 9. Right, the second most common pancreatic tumor is the pancreatic neuroendocrine tumor. And these arise from the islet cells, and they produce a range of endocrine symptoms depending on what islet cell that they are arising from. They show low-grade malignant behavior, so they're not like ductal carcinoma of the pancreas where it gallops off. They tend to remain confined to the pancreas for a long time. Here's Steve Jobs. He famously got a pancreatic endocrine tumor and died of it, but he had it for 10 years or more before he did that. So the most common of these is the insulinoma that produces insulin and comes from the beta cells in the islets. About 10% of these will metastasize to the liver, and the rest of them will just sit around causing trouble producing insulin. And just about every kind of cell can produce its own tumor. So we have glucagonomas producing glucagon from alpha cells, etc. Okay, again, they form a mass, a discrete rather than infiltrative mass in the pancreas. They have cells in them that have neuroendocrine granules in them that secrete the hormones that they are producing. And you can see, being a very discrete, isolated mass, they are more amenable to surgical removal. That brings us to the end of the must-know facts for gallbladder and pancreas. Thank you.